I would like to thank Al-Qasimi Hospital for giving us this opportunity to be part of the conference. And today our session about medical retina and the multimodal images. My name is Dr. Nur Mansouri. I'm vitreoretinal surgeon, medical director of Samaya Specialized Hospital here in Abu Dhabi. And for the sake of time, we'll start with the first session. Please, can you show us the introduction? So our first speaker is Dr. Dinesh Talwar. He's a senior consultant eye specialist, vitreoretinal surgeon from Apollo Interprastha Hospital, New Delhi, India. He's a director and vitreoretinal laser service, and he works in New Delhi, India. And he will start his topic about fluorescein angiography. And I think fluorescein angiography is a very important tool that we need always to use as a second hand in different medical cases, medical retina cases. The floor is yours, Dr. Talwar. You can start your presentation.
Thank you, Dr. Noor. I'm just sharing my screen now. I hope I will be able to stick to the time limit that you have allotted. And so fluorescein angiography, is this today extinct? Or is this alive and kicking? From what you started off with, it seems no. You agree with me that maybe there is a role for fluorescein angiography. But there's a tendency for people to believe that now with the newer modalities, fluorescein angiography has no role. So let's see. I'm going to concentrate only on those areas where I believe fluorescein angiography fulfills a role which nothing else can do. So let's have a look at this. Diabetic retinopathy. Can you, with a fundus examination or OCT, look for eye ischemic maculopathy? No, you can't. But on fluorescein angiography, it shows up very well as breaks in the FAZ, the enlargement of the foveal avascular zone, and so the diagnosis is simple. The only alternative to this is an OCT angio. What about this? Clinically, it looks like a maculopathy. Actually, there's a huge area of neovascularization. If you looked carefully enough in this photograph, you would be able to find it. But fluorescein angiography gives you the answer in seconds. Even more important, you have a patient whom you've decided to do some focal laser. Where are the leaking spots? You can only find that out by fluorescein angiography. You can't detect it from OCT. You can't detect it from OCT angio. Only fluorescein angiography will do the job for you. Whereas where age-related macular degeneration is concerned, clinical classification, the classification of the various subtypes, including the atrophic dry macular degeneration, can be made by OCT. Fluorescein angiography is not necessary. Neither is it necessary for making a diagnosis of exudative ARMD. This is the classic type showing early network and then further leakage in the late phase, or occult CNVM where there's a late leakage from an unknown source, or an RPE detachment. But a fluorescein angiography can give you a global view of what's going on, the proportion of classic and occult form, and that can help you in prognostication of your case. Even more important, it can help you to get a very clear idea of whether you can now do a cessation of treatment, especially in myopic CNVMs and type 2 CNVMs. In this case, you can see this is a staining of a scar with good, well-defined margins, slowly increasing late hyperfluorescence. Look at this one. The fluorescein angiography, the OCT shows an active CNVM here, not easy to diagnose. Over here, it shows it's a healed CNVM. But how did we make this diagnosis? The active CNVM is very clearly seen on a fluorescein angiogram. You can see this. There was early hyperfluorescence, increased and increased further in the late phase. But when you've done the treatment, now you see this early hyperfluorescence, and if a fluorescein angiography later on showed completely healed lesion. An OCT cannot make that diagnosis easily, neither can an OCT angio. In CSCR, you cannot figure out where the leaks are except by a fluorescein angiography. If you want to laser this, you need the angiography. Is it a multifocal CSR? Again, you need a fluorescein angiography. And is it a chronic, or is it a chronic CSCR with a diffuse sick retina, again, a fluorescein angiography is probably the best way of making the diagnosis. Even more important is when you want to differentiate a CNVM from an active choroiditis. Now you see this early hypofluorescence followed by late hyperfluorescence is characteristic of an active choroiditis, as opposed to early hyperfluorescence followed by late increasing hyperfluorescence in an active CNVM. You see this patient? The biggest problem comes where you have an inflammatory CNVM developing in a choroiditis lesion. This was a healed choroiditis, only window defects. You do this, you see the patient complained of blurring, and you can see she's developed an area of early hyperfluorescence, increasing late hyperfluorescence. A CNVM has developed. You would have missed this on every other test. Again, making a diagnosis of recurrent choroiditis is easiest to do early hyperfluorescence, late hyperfluorescence on a fluorescein angiography. So ladies and gentlemen, fluorescein angiography, I believe, is extremely important in diagnosis and management of macular disorders. Even now, there are specific situations where it's probably the most effective method of making and quick method of making a diagnosis. So don't get fooled. It's not obsolete. It's not extinct. Let us not throw away the baby with the bathwater. Thank you very much, ladies and gentlemen. I can't hear you, Dr. Noura. Are you there? You're muted, Dr.
Yes.
Noura? Yeah.
Thank you, Doctor. Thank you for your nice presentation of our important tool in our retina investigations. I would like to remind all the audience to write their question and answer in the question bar. And from our panelists, do you have any question for Dr. Telwar before we start next session?
Yes, I have a question. Can I?
Yes, please.
Thank you, Dr. Telwar, for this quick and nice presentation. And I know fluorescein angiography is still in the market, and I don't think it will be obsolete for a long, long time. But what's your opinion about combining both of them, fluorescein and OCT, and getting more and more data? How you feel about that? I mean,
perfect.
You always order fluorescein only?
Always. No. The best way to make a diagnosis is to combine fluorescein angiography with OCT. And if you have a doubt, add OCT angio to it. If you combine all three, you get a perfect diagnosis. The chances of going wrong are very little.
Great. That's what I wanted to hear, and this is a very good message because we always count on multimodal imaging nowadays. That's why the title, because when I spoke to Dr. Amdi, the title is very good. Multimodal imaging is very important. Fluorescein is still there. It's a keystone, but we're still combining many instruments will give us a better understanding what's going on in the retina. Thank you so much.
Dr. Fahad, we cannot hear you. I think you are muted.
Yes, he is.
Can you hear me now?
Yes.
Apologies. No, just to kind of reinforce, first of all, hello to everyone on the panel, and thank you for your kind invitation. No, just to reinforce Dr. Talwar's point, to me, fluorescein is still very important. Although the non-invasive modalities has meant, or the multimodal imaging modalities have meant that I don't have to rely on it as often for diagnosis, it still has a very important role, particularly for determining leakage. I still think it's the best modality for identifying ischemia, but particularly peripheral ischemia. I mean, who knows how the technology will develop and whether its role will narrow, but still, sometimes you can't get a handle on what is going on with the eye condition without fluorescein angiography.
Perfect. Thank you so much for the nice discussion, for the nice presentation, Dr. Telwar. So our next presentation is by Dr. Majdi Musa, and he's Professor of Ophthalmology, Vitreoretinal Consultant, Director of Medical Retina, Faculty of Medicine, Tanta University, Egypt. And he will discuss about OCT. The floor is yours, Dr. Majdi.
Thank you, Dr. Noura. Thank you. I think you can see my screen. So as I said, multimodal imaging is important, but my topic is related to OCT, so I will keep my topic about OCT today. So we all know that OCT is considered nowadays as indispensable tool in the diagnosis and management of different macular disorders. and recent segmentation of the retinal layers into 14 segments by OCT, especially with the high definition OCT. It's another issue to distinguish different layers as a biomarkers, as a diagnosis and management of macular disorders. And each layer had its significance nowadays while you are considering the visual outcome in these patients. So let me speak about the sweat source OCT, because my whole experience in the last 5 years about sweat source in the management of vitreomacular disorders, and I will highlight three topics. The first one of them is vitreoretinal interface, where there is a vitreomacular traction or vitreomacular vitreoschisis. And then the second topic will be about the inner retinal segment, where macular edema is the main topic, and the last one is the outer segment with CNV is the main topic. Let's go about to the OCT at the vitreoretinal interface. And it's one of the revolutionary thing happened to us in the last 10 years using OCT at the vitreoretinal interface, where we can see myopic traction maculopathy. And it's a...
So just single click on your screen?
Yes, that's what happened. And then vitreomacular traction and then epiretinal membrane. And as I said, I will concentrate on the high myopia. So at the vitreoretinal interface in high myopia, we can have a small line scan, but if you had a longer line scan like 9 millimeter, we'll find out more and more of the vitreous. And another 12 millimeter line scan, we'll see what's going on. 3 layers of the vitreous plus the epiretinal membrane inducing macular traction. So it's very important to distinguish between the hyaloid and the epiretinal membrane when we diagnose and manage myopic traction maculopathy. What is the pathogenesis of myopic traction maculopathy? It's a unique combination of tangential traction, either by the epiretinal membrane or the attached posterior hyaloid, and posterior elongation of the globe and scleral stretching. So this is what induces myopic traction maculopathy, as we can see here. We can see how the macula can be stretched, but to a limit, and then starting the bowing of the posterior pole with the sclera leading of separation of the retinal layers. So what is the natural course of myopic traction maculopathy by OCT? First thing, spontaneous resolution, which is very rare, but sometimes we see it. This is a patient I did phaco, and 6 months later, I found all the tractional element is gone, probably because of the posterior vitreous detachment. How about the stable course? There is a stable clinical course in some cases, and you follow up the patient for years with a stable vision, and you don't need to do surgery for these cases. However, there is a progressive course where progressive increase in the axial lens or foveal detachment and deep staphylomas will lead to myopic traction maculopathy complications. What is the complication of myopic retinoschisis with myopic traction maculopathy? We have to monitor this patient to avoid the myopic traction maculopathy macular hole, which is the end stage. Like this one, progression of the epiretinal traction with severe foveal detachment. Then we go to thin fovea with lamellar macular hole. Then we go to full thickness macular hole. So we should not watch out the patients until they reach this limit. So progressive myopic traction schisis, sometimes the patient is afraid, the patient denied, the patient refused the operation. This is the patient with 624 vision. And then during the progression, he developed more and more lamellar macular hole and foveal detachment. And then she developed more and more foveal detachment where the vision dropped to counting finger. Then the patient agreed to do the operation. And this is what happens if you follow up this patient. So the surgical management in this case, you have to do pars plana vitrectomy depending on that progression and the visual acuity, and then you fill the eye with the gas or silicone. Episcleral macular buccal is necessary in some cases where the posterior staphloma is very high, and suprachoroidal injection of hyaluronic acid is rarely used nowadays. But this is a preoperative, this is my case, and this is the post-operative 8 weeks where the patient regains 636 vision. We do ILM peeling, we do gas in these cases, we don't do silicone oil, which the patient was pseudophakic, and I was lucky. Sometimes when you have a huge posterior staphloma like this, even the sweat source could not get the posterior part of the staphloma. So this is a myopic traction maculopathy with macular hole. Sometimes scleral buckle, macular buckling is important. And even with macular buckling, and you see in the picture, the hole is not completely closed. Let's move to the second part with the intraretinal changes, where we see diabetic macular edema. Diabetic macular edema, nowadays, to start to treat the patient, it depends on OCT. To know if it's a center involving or not, fluorescein angiography cannot answer this question most of the time. So on the left side, it says center involving, on the right side, it's not a center involving. How about the amount of retinal thickening and the types of macular edema? We have many things: cystoid edema, loss of molar fibers, intraretinal hyperreflective foci, outer retinal rail destruction. So all these can be distinguished by OCT only. And this is one of the biomarkers we look for, the outer retinal layers, where the disruption of the external membrane and ISO junction, the bad prognostic sign, rupture of molar fibers, hyperreflective foci, These are all biomarkers for chronicity of the patient and bad visual prognosis. How about treatment? OCT is very important in the follow-up of patient after injections. We know that the patient is the edema is completely resolved, and this is what we call good responder. Sometimes the response is not good. We know that good responder or bad responder or non-responders depend on OCT. And this is very crucial in deciding when to inject, when to switch, and when to shift to another drug. Also, the last part of my talk is about OCT in CNV. We used to combine fluorescein and OCT in defining type 1 sub-RPE, type 2 above the RPE or subretinal, and type 3 intraretinal or retinal angiomatous proliferation. But I think nowadays OCT is quite good enough to distinguish type 1, type 2, and type 3. And sometimes we do fluorescein angiography to distinguish the cause of CNV, like angioid streaks, like inflammatory causes. But OCT is quite good enough in distinguishing type 1, type 2, and type 3. Also in the management, to start treating the patient, we need the OCT. While following up the patient, we need when to stop or when to extend. So this is after 3 injections where the retina is completely dry, flattening, loss of subretinal fluid, and resolution of the intraretinal edema. And this is when we start to extend the treatment. So again, OCT is very crucial in the decision on to stop treatment or to extend the treatment. So my take-home message is OCT becomes the most valuable tool in diagnosis and management of different macular disorders, and it is indispensable tool at the vitreoretinal interface, and it's the tool of choice in detect biomarkers for diabetic macular edema. And nowadays, most of the clinical trials depend on OCT in the follow-up and management of different pathology. Thank you so much for your listening.
Thank you, Dr. Majdi, for this nice presentation regarding OCT investigations. And I would like to remind all the audience to put their question in the question and answer bar. Any question from the speakers for Dr. Majdi Musa regarding OCT? Yes, go ahead, Dr. Fahad.
Thank you, Magdi, for an excellent talk. So obviously, OCT is really good at identifying or diagnosing exudative disease. Do you think there are what are the good markers to guide the clinician that there's utility in continuing treating a particular maculopathy or retinopathy?
I mean, OCT is always a very good guide. I mean, but you should understand what OCT is implicating. You should not take one line and say this, the macula is dry or the macula is fine. No, it's the cube is the very important. You will take multiple line scans. So you have to find out what is going on at the level of the vitreoretinal interface, inside the retina, and the outer retinal layers. So all of this has to be combined when you're looking at your OCT. OCT, as I said, is very good in diagnosis and management and visual prognosis. So not to look at one line scan and saying, that's it. No, you need the cube. You need to go thoroughly through the cube to know what is going on, because the decision of re-injection, the decision of continuing treatment mainly depend on OCT.
Thank you.
I'd like to reiterate, sorry.
Yeah, go ahead, Dr. Talwar, yes.
I'd like to reiterate one point only, which I said in my lecture also. The only place where OCT does not work very well in CNVM is a myopic CNVM, because these CNVMs have very little fluid. Sometimes it's just the mask. So if you know, once they heal also, you'll still find a little bit of the mount still there. So this is a situation where a fluorescein angiography should always be done before you say doesn't need any more treatment. And myopes are one of those indications where you don't need to give too many intravitreal injections. They respond very well to the treatment. So before you say no more injections, you must do a fluorescein angiography in this situation. As a rule, OCT is great.
Exactly, as well, I think it's a very safe non-invasive procedure, and I like always to explain to my patient, showing them pre and post injection, so they will understand the pathology of the disease more, and they will be integrated in the management plan. That's why it's really important to have OCT as well and all the multimodal images. And thank you, and I think we can move to the next speaker. So our next.
You're muted, Dr. Fahad.
Sorry, is it myself or is it Dr. Salam?
Yeah, okay, sorry.
It's you, Dr. Fahad, right?
Yes, I'm happy to share my screen. Thank you, sorry about that. Can you see my screen?
Yes.
Yes.
So I'd like to thank everybody for, again, for the kind invitation for me to kind of discuss kind of OCTA. So this is an example of an OCTA slab in a patient with diabetic retinopathy. this is a real breakthrough in non-invasive retinal imaging, where by just acquiring 2 types of OCT scans that are separated by a particular unit in time, the algorithms are really good in detecting differences between those 2 OCT scans. So essentially, the algorithm is clever enough to work out what is fixed and only analyze what is changing, which is interpreted to be flow or blood flow, and it's able to reconstruct the vascular bed to quite impressive detail. And in fact, if you were to look at a slab histologically of the retina, you would find that the OCTA slab closely mirrors the OCTA slab closely mirrors histology. And that to me is just amazing to think that, just using 2 high volume OCTB scans, you're able to demarcate the vascular beds. And it's really important that whenever you interpret an OCTA, you look at the B scan with the flow superimposed on top of it. So here where a structural B scan, you've got these yellow markings, and this is where the algorithm has determined that there is blood flow. And as you can see, you've got blood flow within the choroid, blood flow within the inner retina, which is where we would expect, no blood flow in the fovea, and there shouldn't normally be any abnormal blood flow in the avascular retina. And that to me is a very good check sometimes when I'm trying to work out how to decipher an OCTA. I always look at the structural B scan and look at the flow characteristics to ensure that what I think is abnormal on the OCTA corresponds to abnormal flow here. But it's quite nice, quite an impressive technology. So it's able to identify the FAS, interruptions are sharply delineated. We are able to identify the microaneurysms. So when we're interpreting OCT, we normally look at that B scan, which is basically looking at that cross section here. But with an OCTA, we're also looking at a lateral or transverse section. And essentially what an OCTA is lots of B scans that are taken together, and then a slab of information is transposed to give you some structural information. But in turn, the algorithm is clever enough to interpret flow within that slab to give you a vascular bed. And essentially, when you interpret the OCTA, you interpret the vascular layers of the superficial capillary plexus, the deep capillary plexus, and the avascular or outer retinal layer, and the choriocapillaris, where the OCTA is not as good in interpreting. But essentially, the OCTA is able. The reason why. Oh, sorry. Because it's a recent development, essentially OCTA, we've exploited the ability of these new OCT machines to acquire lots of scans very quickly, high volume, high detail. They're taking sequentially over time, and what the machine is doing is reconstructing the structure, but also the blood flow by looking at the differences between those 2 B scans. And what's impressive is that you're able to delineate the vascular abnormalities or the vessel delineations of the superficial vascular plexus, the deep vascular plexus, and most importantly, the avascular layer, which should be normal. So any abnormality within that is going to be abnormal, and it's how you're going to be able to identify your choroidal neovascularization. And any decrease in perfusion or flow void within the vascular layers is going to identify macular ischemia. So very powerful, and you can be really sure about what's going on at the macula, and gives you additional insight to those structural changes that you're seeing on the OCT. So, like I said to you, OCTA you interpret in terms of slabs. So when you interpret the OCTA, you look at the superficial vascular plexus, those interconnections, intermediate capillary plexus, the deep capillary plexus, and the avascular layer, which I said is completely black and should not have any abnormal flow within it. But what's impressive is that when you look at the histology, the capillary bed looks very similar to this OCTA interpretation, which is remarkable when you think how far the technology has come. And this is just labeling the point. What the OCTA algorithm is doing is looking at the B-scan video, and it's determining in terms of probability whether this is tissue and whether this is flow. And if it's flow, it's then contributing out to the OCT image that then you see when you come to interpret these images. Without further ado, we'll quickly just move through some of these slides, just so we can interpret some macular ischemic slides. Sorry, 1 second. Do apologize for this. I'm going to try my best to get that up again. I do apologize. Sorry, I just wanted to quickly go through some of the OCTA examples rather than actually going through each of the individual slides. So just bear with me, I do apologize. So here we go. I'm going to share my screen very shortly. Brilliant. So and I've given you some of the background. So this is somebody with a inferior branch retinal vein occlusion. The macula is dry. There is no fluid within the macula. However, they're not quite happy with the quality of vision that they have. I wasn't convinced that there was much irregularity within their retinal layers. So I couldn't be confident about why this patient with a fairly resolved retinal vein occlusion didn't see very well, and particularly there weren't any treatments for me to offer. Clearly, I had suspected that the vein occlusion was the likely cause, but I got an OCTA. And as you can see, this is the kind of layout that you will see. So you'll see the transverse structural OCTA with the blood flow. And then it will show you the slab that you're studying, which are these two red lines here. So I know I'm looking in the superficial vascular layer. And as you can see, there's probably, the FAS is probably okay. There is some interruption within the vascular bed inferiorly in contrast to the superior vascular bed. So I could be very confident to say to the patient that they have lost some quality of the vision because of the effect of the vein occlusion on that capillary bed. And then when you go into the deeper vascular layers, so again, the machine shows you exactly the area that you're studying. And then this is the deeper vascular bed or the deep capillary plexus. And as you can see, there is flow voids within the inferior vascular bed compared to superiorly. So I could be much more confident that unfortunately, although he's done reasonably well in that he hasn't had too much disability from his vein occlusion, it has affected the quality of vision to a degree, and I could counsel the patient accordingly. This is a patient with a myopic choroidal neovascular membrane, and I could see a small hyperreflective lesion within the outer retina. I co-localized it on the transverse OCTA, on the structural OCTA, and you could see with the eye of faith, there's an abnormal flow of blood within the avascular layer complex, where this should be black. And then if you look at the flow signal, you can see within that area of hyperreflectivity, there is some yellow. So I could be confident that not only was this a myopic CMV, but there is abnormal flow through it with a symptomatic patient. So I was happy to treat them. And then when you look further down into the choroid capillaris, again, there is some abnormal flow within the choroid capillaris that corresponds to this lesion that lights up yellow, again, within the choroid capillaris. So I can be confident that this was a CMV, so I treated the patient. And then this is the last example. This is somebody with wet age-related macular degeneration. they have a hyperreflective lesion on the structural B scan with a slither of subretinal fluid. They are symptomatic. Pre-OCTA, I would have got a fluorescein angiography to identify the abnormal CMV. However, now we have OCTA. So again, when looking at the avascular complex, and I can be confident that's the area that I'm looking at because of where the slab lines are. You've got an increased signal of abnormal vessels or abnormal flow within the avascular complex. And as I said to you earlier, we do not expect to be any flow within the avascular complex. So this is pathological. And if you look at that area of hyperreflectivity, you can see there is some yellow within it. So I can be confident that there is flow in that hyperreflective lesion, and that hyperreflective lesion represents the CMV. And I went ahead and treated the patient. And again, if you go down into the choriocapillaris capillaris, you can see that there's this abnormal network of blood vessels within the choriocapillaris capillaris. So again, you can be confident about the choroidal origin of this abnormal network of blood vessels. So OCTA, although it hasn't in my practice necessarily stopped or obviated the need for fluorescein angiography, it has meant that I've been able to use it much less frequently, that I've been much more confident in treating. But essentially, in the way I've structured it, I would still use OCT, use color photography, use biomicroscopy, look at the patient's symptoms, and then interpret the OCTA before I make a diagnosis. But essentially, it's the machine very cleverly looking at two structural OCTs, looking for the difference, and interpreting that as flow. So just be careful that sometimes, when you're looking at some neurosensory detachments where there may be flow within it, the OCTA machine may, as an artifact, describe that as abnormal flow. So still, if need be, if you're not sure, do a fluorescein angiogram. Thank you.
Thank you, Dr. Fahad. Thank you for your nice presentation. And any questions from the speakers for Dr. Fahad regarding OCT angiography?
I have a comment only, not a question. Yeah. Go ahead, Dr. Talawi. No,
go ahead. After you.
No, after you.
Okay, 2 points. One, I think great points being made. One thing is to highlight that's the importance of the deep capillary plexus. You see, a fluorescein angiography cannot differentiate changes in the superficial and deep capillary plexus. They come together. So like you showed in a BRVO, subtle changes in vision, you think that the superficial plexus is normal, but there's a problem in the deep capillary plexus. So we are finding these subtle changes as responsible for vision problems, and that's an important thing. The other important thing is, while the OCTA is great for type 2 CNVMs, very often in type 1 CNVMs, you could miss. So when you see the lesion, yes, it's proved. But if you don't see the lesion, it doesn't mean there's no, there's no CNVM. So that's the important thing. And third thing is, be very careful about projection artifacts. Supposing you have an RPE detachment, sometimes you'll see you start moving down, you'll see as if there's some vessels. Actually, that's part of the normal retina. So you have to be careful about projection artifacts. And also, to be very sure, it's good to do manual segmentation. So, this is the automatic segmentation which the machine does. But if you do a manual segmentation, sometimes a lesion which is, say, in the outer retinal layer and capillaries, choriocapillary layer, when you do the segmentation, you can see where it's arising from, how it's been enlarging, and when it's disappearing. So that it prevents you from making mistakes about projection artifacts coming into the picture. So,
Dr. Talwar, thank you for those comments. But no, your point about the if there's no flow, no abnormal flow in OCTA in a patient in whom I suspect CMV, I always request a fluorescein angiogram. But no, those are really good comments. Maybe you had some comments?
Yes, he covered many points, but one more point, not the flow, the pseudo flow. Sometimes you have a flow and it is not a CNV. So this is a new entity. Again, OCTA is very, very crucial in interpretation. It needs more and more time. It needs a very good, understanding what is going on. So the pseudo flow sometimes tell you there is a CNV and there is no CNV. So this is the reverse. My last comment is OCTA in pediatric age group. It's magnificent. Sometimes you find a dystrophy a long-term best disease, and you never expect there's a CNV down there. I have a case with telangiectasia, 10 years old, and I found a CNV. So sometimes OCTA is the only clue if you have a CNV in pediatric age group. So this is another entity we have to consider doing OCTA, non-invasive for children. Sometimes it's the clue in these cases.
And Dr. Magdi, in continuation with this, sometimes you have adult vitiliform degeneration, which is misdiagnosed as CNVM. So if you've done an OCTA, there's no way you can miss it, because if there's no CNV in that, you don't have a CNV.
That's a confirmation by exclusion. Yes, that's a very good point again. Thank you.
Perfect. I think our next speaker is not among the audience, and it's not in the panelists, which is Dr.
Hi, Dr. Noura and everyone. Dr. Abdallah has apologized to Dr. Amri. I think it may not have been communicated very well because he's operating today.
I see. Then I think we will move to your presentation.
Excellent, excellent. Thank you so much.
Thank you.
And very happy to be here with you and Dr. Musa and Dr. Talwar and Dr. Kohel. Thank you. I'll start sharing.
It's our pleasure. Yes,
thank you so much. And I just want to confess, I thought I'd choose ICG because I know it's not widely practiced. So then I was hoping not to get many questions. So.
Oh, you will. You will. Don't count on that.
There's no way out then. I thought I'll let me just all right, can you see my presentation?
Yes.
Okay, can you see like a full screen or off screen?
So we are on screen. It's the pink one.
All screen, okay, all right. So I chose like few topics. So in medical retina, when do I do ICG? I mean, we're very fortunate here that we have access to ICG, and I know that the dye can be not very accessible in some parts of the world. So we're very fortunate to have it and very easy to order. But in medical retina, we order it mainly in several diseases, mainly when we're thinking of a macular disorders in relation to neovascular AMD. And the reason, could this be a RAP? The second one, if we're suspecting IPCV, and also in CSR, particularly under two situations. One, if we're thinking, is this a CSR or an IPCV? And the second one, if we're going to treat with PDT. That's three when we usually order it in medical retina. Otherwise, I think fluorescein would do so well. Just to like summarize. Okay, so in neovascular AMD, I'll just show you some pictures here. There's a patient presenting with mainly exudates and maybe a grayish membrane under the retina, not very obvious in that picture. You can see it very nicely here with the fluorescein. With the ICG, you can see the plaque lesion, which does not leak as it leaks in the fluorescein. So this is a classic CNV. And just to refresh your mind, these are the pictures together with OCT. And that's after treatment. Okay, and then here is an ocular CNV, something happening here on the fluorescein, not too early, but something happening a little bit on the mid phase. And ICG, again, not very conclusive on the ICG. So it's not that helpful in classic and ocular CNV. And then here you got the OCT picture. Okay, let's see a video here. That's a myopic patient. And really, the ICG is not very helpful with occult and classic as per like the diagnosis. I think the fluorescein gives it all. But sorry, that's actually, I'm sorry, that's a fibrous classic CNV. So then we move to a case here. She's a 66-year-old female, decreased vision. And this is the clinical picture. And you can see here, I mean, there's subretinal exudates, also some intraretinal exudates, and the hemorrhage is superficial for wet AMD. So a picture may be suggestive of even a diabetic macular edema, but I mean, if you think about it, it's actually, it could be something else. It could be a RAP lesion, which is a mix of, You have a PED as well as a picture that may suggest macular edema, like a diabetic type or something with exudates and more superficial hemorrhage. So if you put these together, that could be a RAP. And that's where fluorescein is, where ICG is very nice. So here the fluorescein, and you can see the vessel dipping there in the PED, and then something happening here with the connection. But you see that much better on the ICG because the PED, it becomes more hypocyanescent or hypofluorescence, the way you want to call it. And you can see the very nice connection there. And again, it's more obvious really with the ICG because there's no leakage from the RAP lesion much on the IPCVS compared to the, on the ICGS compared to the fluorescein, as you can see on the right side. And more on that. And then here, this is a cut through the PED, and you can see really the hallmark of diagnosing a RAP lesion, which is the PED, and on top of the PED, you have the intraretinal edema. So that's more of a type 2 RAP disease or stage 2 RAP disease. And then here you have the stages 1, 2, and then stage 3, where you actually get a choroidal neovascular membrane as well, because there's a retinochoroidal anastenosis. And that's another picture here, and you can see it more on the green filter. And that's the same thing here. And that's a very nice picture, shows you all what's happening really. And I think the one good differentiator on the OCT is that with the RAP, things are happening from up to down rather from down to up, as you see more on the classic and open CNP. So if you think about it, something happened in the retina, leaked, and then created the PED, while they actually choroidal retinal interface more or less clean other than that PED. And that's a picture here from the internet. And then, I mean, I think we had a talk about OCTA, but just to cover OCTA on that, it's mainly the deep vascular plexus where it's really very obvious, and then it dips down a little bit. You can see it on the superficial vascular plexus, but it's mainly in the deep vascular plexus. Okay, and that's another case as well. And the same thing here, so not too much leakage, but again, the same thing, the PED and the RAP on top. And this patient did fantastically well. And interestingly, they need less injections and they do so well. They may get retinal atrophy. That's the problem with anti-VEGF injections. I think Naomi Lewis was the first one really to suggest that, and that was sort of like neglected, and people said, no, that does not happen, but the CAT study also alluded to this. Okay, and last one is IPCV, and you can see here, this is a very nice picture. It shows the vascular networks, it shows the polyps, and it shows the PED. And if you think about it as vascular networks, and then it leaks and creates the PED and raises the PED and raises the pigment epithelium as PED. And that's a nice picture here. It shows really the classic presentation where you have, it can look like a wet AMD, but you have more hemorrhages, you have more hemorrhagic PVD, you have more extensive exudates, and usually it's in the macula, but it also could be in the peripapillary region. And I'll show you here, there's a patient here where with fluorescein on the left side, you think this is more of an occult. With the ICG, you can see the polyps there. And that patient as well responded. And we treated only this patient with anti-VEGF injections. We did not use any complementary PDT. And that's another case. And again, polyps here, and which you can easily miss on the fluorescein. Does it change the management? I mean, the errors to show that it actually, they may do well with a combination of PDT and anti-VEGF. So it may change, at least really, you know, that they may need more treatment, you may consider PDT. And that's another case here with the PED and the polyp, and that's why the PED may look like irregular, like, as they call it, a sleeping snowman. And that's another case here where a patient presenting with exudates and something happening around the disc. And that's the OCT here on the fluorescein angiogram. And you can see it so nicely with the ICG. I mean, here on this one, I think with the fluorescein, you can tell that this is an IPCV in combination with the OCT, but you can see it more nicely on the ICG. And thank you so much.
Thank you, Dr. Salam, for the great presentation regarding our nice, great tool, which is ICG. And unfortunately, it's not available for use everywhere. And
that's why I chose that topic. Because I'll get away without any questions.
Because it's a very unknown part. You might have plenty of questions, by the way.
Yes. Can I have a question, by the way?
Of course, yes, of course, yes.
Nice to see you, Dr. Ahmed. Let me ask you, you still use it in uveitis? Because I know you have a long...
Yes, we do, yes. And we'll cover that. I think there is a uveitis talk where I'll cover that. So in uveitis, it's mainly to look for choroidal disease. And the question really, is it a stromal choroidal disease, for example, birdshot, or it's an ischemic or like a primary choriocapillary disease as ischemic choriocapillitis, like, for example, what you see in MP. And they look different. Yeah. So that's the main use really in uveitis.
Yes, that's what I thought, because even in a PCV, you showed us very good examples, but I think OCTA is, again, very helpful in PCV more. Combining OCT and OCTA is going to be to replace ICG, but I think it is not replaceable for uveitis, because uveitis, you need the periphery, you need the level, you need to know what's going on in the choroid. So I don't think OCTA can cover this up to now, but I think uveitis is still a very undiscovered by all other multimodal imaging.
Yes, especially when you're looking for choroidal disease.
Yes, yes. Thank you so much.
Thank you. Yes,
no, just to reinforce the commentary about ICG, particularly in uveitis. So there's been the odd AMPI case where possibly on the OCTA, you might see some flow defects within the choroid capillaris, but any more deeper than that, you're not. I just don't have any experience with the sweat source OCT. So my OCTA is mainly Heidelberg, and it just doesn't penetrate as deeply. So ICG, still, I have to say, my own practice is to diagnose polyps. I'm still not as confident with the OCTA to diagnosing them, but also, any birdshot, any, choroidal inflammation, ICG has been really helpful. But yeah, it's something I probably do once every 3 or 4 months. It's not as frequent as it may have been, say, 5 or 10 years ago.
I think one thing is, though, thank you. Those are beautiful photographs, and you've shown very clearly how ICG is the gold standard for both PCV and even in RAP lesions. But the important thing is that don't fret if you don't have ICG. The important thing is that the OCT picture of a PCV is fairly characteristic. The peaked PEDs, which you showed, and the double layer sign with shallow irregular RPDs is virtually characteristic of a PCV. In a RAP lesion, when you see these RPEDs with multiple intraretinal cysts, and sometimes you can actually see the CNVM on the top part of that lesion, you're reasonably sure you're dealing with a RAP lesion. So in both these situations, you get enough clues from the OCT, and if you have an OCT angio, it adds to the information that you get. But yes, even today, I think the gold standard does remain ICG. As you said, in uveitis, it has a role which is underplayed. It needs to be sort of highlighted much more. And that's one place where we should be using it more, especially in choroidal, disorders. So I think that was a great talk.
Thank you. I'm sorry, I'll have to head to clinic. Thank you so much. And thank you, Dr. Noura, for the moderation.
Thank you, Dr. Ahmed Salam. Thank you. I think my last question for all the speakers, and we are about to finish our webinar. If there is two tests that you would like to have in your clinic, which one you are going to choose? We can start with Dr. Majdi Musa.
If it's in the macular area, I will be quite good enough with OCT and OCTA. Only the macular area, OCT and OCTA can give me a very good clue. Plus the color picture, of course.
Exactly. Dr. Talwar?
I think for a beginning surgeon, a fluorescein angiogram and OCT is best. And next thing to add is an OCTA. It'll take care of all the first two investigations take care of all the possibilities that can happen, except that the FA is a little invasive.
Exactly. Dr. Fahad?
OCT with a fluorescein with a Sterangi white field lens. If I was really pushed, that's probably what I would go for.
Perfect. Thank you so much. Dr. Mohammed Al-Umari, would you like to add something to our session?
Thank you very much. I want just to say hello to all dear friends.
No,
Dr.
Mohammed is
Zaid
coming to finish
Dr.
the session. Mohammed is coming in to finish the session on time, not
We
to
are on
say
time.
anybody. Yes, we are exactly on time, exactly on time. So leave us alone and say goodbye. Don't say hello, say goodbye, and that's it.
Okay, now
Hello, Dr. Majdi. Thank you very much. It was an excellent.
Thank you.
Thank you, Dr. Honora.
Thank you.
Thanks a lot. Dr.
All right, well,
Fahad,
take care, guys.
Dr. Danish, all.
Thank you
Bye-bye.
very
Thank you,
much.
Thanks a
everyone.
lot.
Thank you.
Bye.
Nice seeing you.
Bye-bye.